Hello, everybody. Welcome back to the Pediatric Masterclass. Today, we'll be continuing with the second part of the clinical presentation on nephrotic syndrome, where we'll cover examination, investigations, and treatment, uh, practical points, a lot of theory, and most importantly, Viva questions. So let's not waste any further time and we'll begin. So just a summary of what we discussed in the last class. So we had a 7-year-old boy who presented with the first episode of periorbital puffiness since 7 days, pedal edema since 3 days, and decreased urine output since 1 day. So we were able to summarize the case or give a diagnosis at the end of history, as this is most likely a case of generalized edema or anasarca of renal etiology, which was most likely nephrotic. We'd seen how to differentiate nephrotic syndrome versus nephritic syndrome in the previous class. This child did not have any atypical features. He did not have any hematuria or any signs suggestive of hypertension. This was the first episode. It wasn't a relapse. So this was the first episode of this periorbital puffiness, pedal edema, and decreased urine output. And he did not have any obvious complications on history. But obviously, we like to confirm that on examination. But this was how we summarized the case at the end of history taking in the first class. Today, we are going to go about discussing the examination, investigations, treatment, and practical points. So let's start with the general examination. First thing that we look at is the posture. So usually kids who have a lot of edema, whether it's ascites, pedal edema, are usually more uncomfortable. Those who have massive ascites, so much so that the diaphragm has been pushed up because of the massive amount of fluid in the abdomen, they are usually um uncomfortable. We try to keep them in a propped up position, okay, so that they're able to breathe okay. So posture becomes very important. It will give you an idea of how severe the edema is, whether the child is comfortable. Even those who have scrotal edema or genital edema, vulvar edema are also very uncomfortable. So it'll give you an idea of how sick the child is and what needs to be done. Next thing, of course, in general examination is the vitals. So vitals, just like any other case, we look at the heart rate, respiratory rate, blood pressure, CRT, and peripheral pulses. From a nephrotic perspective, the respiratory rate becomes important because these kids can have tachypnea. Now, the reasons of tachypnea in a child with nephrotic could be many. Most commonly, it's either because of gross ascites that has pushed up the diaphragm. That is one reason. Second is if the child has associated pleural effusion, again because of transition of fluid from the abdomen into the pleural cavity. If they have coexisting pneumonia or a respiratory tract infection, that is another cause for tachypnea. And last but not the least, this is something that we discussed in detail in the last class, that these kids with nephrotic are at a higher risk of having thrombosis, okay, because of the hypercoagulability. So pulmonary embolism, although rare, is another differential diagnosis should be kept in mind in a nephrotic who's presenting with tachypnea. Once you've ruled out the more obvious causes like the diaphragm being moved up because of ascites, pleural effusion, pneumonia. But if you still feel that after ruling out these conditions, the child still has tachypnea, which is unexplained, you should always keep pulmonary embolism as a differential in mind. Okay. Next important thing is blood pressure. So blood pressure, the hypertension is defined as blood pressure more than 95th percentile for age. So from a nephrotic perspective, there are two important reasons why blood pressure is important in your vital examination. One is that blood pressure is not an usually associated finding with a nephrotic, but if you have associated hypertension, it again points towards either atypical features of nephrotic or probably even nephritic syndrome, because nephritic have hypertension, which is a very predominant feature in them, whereas it is not a normal feature that you will see in nephrotic. So that's one thing that you need to keep in mind. It's either an atypical feature or it could be a coexisting nephritic syndrome. Another important thing is when the child is on prolonged steroids, okay, that itself is a complication that hypertension happens because the child has received steroids for a longer duration of time. Okay, so side effect of steroids is hypertension. So that is again why blood pressure monitoring, especially if you have a child who's a chronic nephrotic who's been taking steroids for a longer duration of time, that needs to be kept in mind. Last but not the least, CRT and peripheral pulses will give you an idea of the peripheral perfusion. Now, this is important because, say, a child, it is more important from a practical perspective. Say you have a child who's presenting with gross anasarca, okay, and you want to diurize the patient. You want to give the patient diuretics so as to relieve some amount of edema. In that scenario, before diuretics are administered, it becomes very important to look at the peripheral perfusion of the child. Like, say, if the child is having hypovolemia, say the peripheral perfusion is poor, CRT is more than 3 seconds, then you cannot give diuretics because, anyways, the intravascular volume is contracted. So, that is the importance of assessing the peripheral perfusion from a treatment perspective. That if the child is already having hypovolemia, then you need to be careful and you might not give diuretics for diurizing the edema. Next important is anthropometry. Like any other case, you take the height, weight, head circumference. BMI again becomes very important here because obesity is defined as BMI of more than 95th percentile. So again, obesity is a complication of long-term steroid use. Another thing is short stature. So short stature, which is defined as a height of less than third percentile for that age or less than -2 standard deviation. Again, this is a long-term complication of chronic steroid use. So obesity and short stature become more important from the anthropometry perspective. Another important thing that we usually measure is the abdominal circumference in nephrotic. Why is this important? Because somebody who's having ascites and say the child is presenting to you, you take an abdominal circumference on the first day and then you take serial measurements every day to see if the ascites is increasing, if the ascites is the same, is it responding to the treatment that you've given, what. So it's basically more for management and daily monitoring purpose that abdominal circumference measurement, which is taken at the level of the umbilicus, becomes very important. So once anthropometry is done, next, so that is in the examination is your head to toe examination. So things with respect to the nephrotic, which are important or what you might see, the number one thing is periorbital edema. Second is pedal edema. So pedal edema usually in nephrotic is the pitting type, and you need to mention that if there is pedal edema, it is extending up to what level? Is it up to the ankle? Is it up to uh, the knees? Is it up to mid thigh? Whatever level that you're able to appreciate the pedal edema up to needs to be mentioned in your examination. Next important is Cushingoid facies. Okay, so again, those kids who are on long-term steroid use will develop these side effects of steroids. So moon face. What exactly is moon face? This is what a moon face looks like. It's nice and round. Then they can have a buffalo hump. If you can look here at the back, this is called as buffalo hump, and a lot of stria on the skin. Okay, so these are complications of long-term steroid use. So Cushingoid facies is something that we very commonly seen in nephrotics, and it will give you an idea that probably the kid has been on steroids for a very long time and has already started developing signs of steroid toxicity. Now, pallor. Pallor is again important because there are various causes of anemia in nephrotic. Number one, most common, like any others, is nutritional. Other than that, iron deficiency anemia is also common or is commoner in nephrotics as compared to another non-nephrotic child. The reason being that along with albumin, they also tend to lose transferrin in the urine. So transferrin is another protein which is lost in the proteinuria, and that's another reason why they're at a higher risk of iron deficiency anemia as compared to the other kids. So always look for pallor. In the eyes, obviously you look for pallor to look for anemia. Now cataract. Cataract is again another complication of steroid toxicity. So that is something you should always examine the eyes for someone who's been on long-term steroids. Other interesting things that can be looked on examination of the eyes is when we're considering congenital nephrotic syndromes. So Buftalmos or your congenital glaucoma is seen in nail patella syndrome, and microporia or very small sized pupil is a presentation of Pearson syndrome. Okay, so this is what nail patella syndrome looks like. Okay, so they have dysplastic nails, all this very rare and a rare cause of congenital nephrotic syndrome. But they'll have, as the name suggests, nail patella, they have dysplastic nails, they have abnormal patella, like a malformed or a, a displaced patella. And they can also have ophthalmos, or if you can see the right eye, that's congenital glaucoma. It's big, it's bulgy, and along with this, they have certain mutations which predisposes them to congenital nephrotic. Similarly, Pearson syndrome is associated with anasarca, like in this image, where you can see gross ascites, pedal edema, and the child is extremely irritable because of this gross anasarca. And microcoria, if you look here, the pupil appears really small. So just theoretically, congenital nephrotic syndrome is associated with a few syndromes. The ones that you need to remember are Pearson syndrome, Neil Patella syndrome, and Denny Drash. Even if you remember these three, it's important. It's okay. It's not a must know, but it's good if you know in case if you're ever asked that do you know some syndromes that are associated with congenital nephrotic. Congenital nephrotic is a nephrotic that is seen within the first 3 months of life. Infant nephrotic syndrome is what develops between 3 months to 12 months of age. Okay, so syndromes associated with congenital are Denny-Drash syndrome, Pearson syndrome, Neil Patella, and if you want to know more, then Galloway-Mouard. So this is just good to know, extra points, and this is why eye examination becomes more important, especially if you have a younger kid who's presenting with atypical features or who's presenting with features of nephrotic, and then you want to associate it with the presence of some other associated syndrome. Okay. Along with that, in oral cavity, we look for oral thrush because again, steroid use predisposes to oral candidiasis. Skin will look for rash, petechiae, and purpura. So skin rash is what we saw like the striae is a complication of steroid use. But at the same time, what we also need to look for are if there are any petechiae or purpura. So like we discussed, there are secondary causes of nephrotic syndrome. One of the common causes of secondary nephrotic is vasculitis. Like you can have SLE, and not calling purpura or HSP. So these conditions present with skin rash, purpura, and petechiae, and they might lead to secondary nephrotic. So that's another reason why skin examination becomes important. Never forget to do an examination of the external genitalia. So always look for scrotal and vulvar edema. Sorry, the spelling of vulvar is wrong here. But always never forget to look for scrotal and vulvar edema. Okay, because many a times when you have gross ascites, there is associated scrotal edema, and if left untreated, can develop scrotal cellulitis, can be extremely painful, infectious, and it will just complicate the course of treatment. So always look for genitals for edema. And the last but not the least, BCG scar, because BCG prevents disseminated tuberculosis infection. Okay, we all know this. Because these kids with nephrotic are going to be put on steroids, which is an immunosuppressant, you want to make sure that you don't uh, you don't cause disseminated tuberculosis infection. So it's always good to look for a BCG scar to see if the child has received it in infancy, and BCG is really good in preventing or protecting the disseminated tuberculosis. Obviously, not pulmonary or cervical or other localized TB, but it definitely helps in preventing disseminated. So BCG scar is something you should always look for. Okay, so we saw this. Now let's move to the systemic examination. So first important point is going to be inspection. So you look at the shape of the abdomen. Is it distended? Is it not? If there is ascites, the first place where the fluid starts accumulating is the flanks. So look at the flanks if they look full. So this is all inspection. So if we've not yet touched the patient, look at skin over the abdomen. So if you look for striae, which again is a sign of steroid toxicity. Uh, so this is what a striae looks like. You look for tense, shiny skin or redness. Okay, so redness of the skin over the abdomen, usually periumbilical or on the sides, may point towards peritonitis or tense ascites, and always look for dilated veins or scars. Okay, so this is if you can look here, peri or by a periumbilical redness, and there's redness in the sides as well. This can be seen in peritonitis, so this is something that you should always look for. Then we look for movement with respiration. So all the four quadrants of the abdomen should ideally move normally with respiration. Even if there is ascites, this movement is usually unimpaired. Unless and until there's gross ascites where you're not able to appreciate the movement, then it's a different thing. The next thing that we look for is umbilicus. So you look at the position and the appearance. So whether the umbilicus is positioned midway in the abdomen or has it been pushed down. So usually when you have ascites, the umbilicus gets pushed down. It's supposed to be midway between the xiphoid and the pubic symphysis, but here because of the ascites, the umbilicus has been pushed down. So this is what it looks like. So this is the position of the umbilicus. The next thing is appearance, whether it's flat, transversely stretched, or everted. So this is what a smiling umbilicus looks like. Okay, it's transversely stretched. You can also have an everted umbilicus, like if there's severe or gross ascites, you can have either smiling or everted. So position and appearance of the umbilicus becomes important in your inspection. Last, like I said, external genitalia, to look for edema, redness, or ulcers, which can point towards scrotal cellulitis. Like if we look here, there is gross uh, scrotal edema. Okay, so you should always look for edema, redness, pain on touching. And a lot of times when these kids have severe scrotal edema, we give them a scrotal support so that, that sagging sensation that they have of it being pulled down is relieved, and it helps in relieving the pain. So that is why external genitalia examination becomes very important, because if there is severe scrotal edema, it needs to be treated accordingly. Okay, so that's the importance of external genitalia, and always look for a hernial orifices. They will usually be normal in a nephrotic, but it's good to look for. Okay, so this is what you look for in inspection of the GIT for a nephrotic. Next comes palpation. So you have superficial and deep palpation. Superficial, you look for any local rise of skin temperature, any signs of peritonitis, any signs of infection, and you look for tenderness, guarding, or rigidity. Most importantly, you look for abdominal wall edema. So how do you do it? You put a stethoscope in the abdomen and gently press it for 10 seconds. Once you leave it, if you have a mark over the skin, like if you look here, now in this picture they've used their fingers. Okay, so you put your fingers on the abdomen and then you gently press it for 10 seconds. The moment you release that pressure, you'll be able to see a mark being left behind over the skin. So this is how you look for abdominal wall edema. That is again interstitial edema, something that you will see in nephrotics. So that was superficial palpation. In deep palpation, you look for any organomegaly. So you look for liver and spleen. Because in the presence of ascites, you'll have to displace the fluid while deep palpation. You'll have to use the dipping method where you're pressing the abdomen with pressure so that you're able to displace the fluid and then try and palpate the liver and spleen. And the third important thing is abdominal girth, which needs to be taken at the level of the umbilicus, and it is something which makes more sense when taken as serial measurements for monitoring the abdominal girth. So we saw inspection and palpation. Next is percussion. So percussion, again, two important ways of looking at it is one is your horseshoe shaped dullness, shifting dullness, and fluid thrill, depending on how severe or how much of fluid is accumulated in the abdomen. This is something that all of you know, so I'm not really going into details of how to do the horseshoe, shifting dullness, and fluid thrill. One theoretical point I'd like to mention is the puddle sign that they say can detect ascites as minimal as 50 ml of collection in the abdomen with the puddle sign. So what you do is you put the child in a knee elbow position. Okay, so he's like kind of prone on his knees and elbows, and you make the child wait like this for 5 minutes. What happens is that when the child is put in the knee elbow position, the abdomen or the periumbilical region becomes the most dependent part of the body, and all the fluid tries to accumulate in the most dependent region, which is around the umbilicus. So once you've placed the child in this position, after 5 minutes, you try to percuss in the periumbilical region and you might find dullness. Okay, this is more theoretical because it is very difficult for us to, put kids like this and make them stay there for 5 minutes and then do the percussion. So it's more for theoretical purpose, but it's good to know if somebody asks you that if there is minimal amount of ascites, say only 50 to 100 ml of fluid collection, then is there any way you can detect it clinically? Theoretically, yes, by doing the puddle sign, and this is how it's done. Okay. And then you always look for auscultation to hear for bowel sounds. Okay. So that's mostly going to be normal in a nephrotic. So that was how you examine the GIT system in a nephrotic. GIT system examinations are usually easy and very straightforward. You don't really have to spend a lot of time in that, and they're easy to do. So once you're done with GIT, you need to look for the other exams. You look at respiratory and So in respiratory system examination, what is important is you look for obviously air entry, because like I said, you can either have pneumonia, which is like predisposed or caused, triggered this episode of nephrotic, or you can have pleural effusion, or you can have associated pneumonia with parapneumonic pleural effusion. So respiratory system examination becomes important usually when you have a nephrotic, because you have to at least auscultate the patient well. CVS and CNS examinations will usually be within normal limits in a nephrotic unless and until they have any associated complications. So you can mention that the other systems are within normal limits, but just have a quick look at them. You don't need to examine them in detail. So once you're done with the examination, which is both general and systemic, we'll come to a diagnosis. So how do you finally give your diagnosis at the end of history and examination? So you will say that this is a case with generalized edema of renal etiology, which most likely is nephrotic syndrome. Once you say nephrotic, you need to mention if it's the first episode or if it's a relapse. Now remember, if you say it's a relapse, then you have to say whether it's a frequently relapsing nephrotic or an infrequently relapsing nephrotic syndrome. We look at those definitions in the discussion soon, but just keep this in mind that if you're uttering the word relapse, say this is not the first episode of nephrotic, then it becomes extremely important for you to mention if it's a frequently relapsing case of nephrotic or an infrequently relapsing case of nephrotic. Next, if it's a relapse, again, you need to mention if it's steroid sensitive, steroid dependent, or steroid resistance. Again, we look at those definitions, but these definitions and these wordings become very important from your diagnosis perspective as well as how you're going to investigate and treat the child. Like, for example, if the child is steroid sensitive, like, for example, this is the second relapse, and every time the child has had relapses, he's been prescribed steroids and he's responded to steroids, he's gone into remission, but he's had relapses again. That means he's steroid sensitive, and steroid sensitive nephrotics most commonly have minimal change disease, which is the most common variety of nephrotic with very good prognosis. On the other hand, if you have a child who has steroid resistant nephrotic, that means that again, it can still be minimal change disease, but you need to keep in mind the differential of other varieties of nephrotic like membranoproliferative, focal segmental glomerulosclerosis, etc. Also, that is number one, that the etiology might change. Steroid resistant nephrotics might have an underlying secondary cause of nephrotic syndrome that needs to be investigated. That's point number two. And third is, as the name suggests, they're steroid resistant. That means they're not going to respond to steroids. So you need to look at what kind of treatment they need to be started with so that they start responding. So you might have to start with steroid sparing agents like you have MMF, levamisole, cyclosporin, cyclophosphamide, etc. So your entire treatment and follow-up investigations in a case of steroid resistant will change as compared to somebody who's steroid sensitive. That is why it gets very important that if you're mentioning it's a relapse, you have to say if it's the first, if it's a frequently relapsing or an infrequently relapsing, and if it is, then whether it is responding to steroids, is it resistant or is it sensitive? Okay. Now, usually a nephrotic is triggered like an episode of either the first episode or a relapse is triggered by some kind of infection. It might be UTI, it might be a URI. So, what infection you think has triggered this episode needs to be written, whether or not there are any associated complications. So, sorry. Complications can be divided into acute and chronic. So, acute complications include infection, thrombosis, and acute kidney injury. So on the basis of your history and examination, if you feel that the child has any of these complications, that needs to be mentioned. Signs of steroid toxicity we saw, like you can have skin striae, cataract, hypertension, short stature, myopathy. All of these are signs of steroid toxicity. So whether or not on the basis of history and examination you feel that there are, then that needs to be mentioned. And last point, like which is common in all your diagnoses, you need to mention the immunization status, the development, and the anthropometry. So this is how you will summarize your case of nephrotic. So you will say this is generalized edema of renal etiology nephrotic, and then mention first episode or relapse. If it's a relapse, mention that more in detail. what was the triggering factor for this episode, whether or not there are associated complications and steroid toxicity, and lastly, immunization development and anthropometry. I hope this part of the discussion is clear, how you've examined your patient and how you've come to a diagnosis. If anybody has any questions till now, then we can take it like here itself, or else we can begin with the discussion. So I'm going to give you like a minute. If you have any questions, you can put it in the chat box or you can unmute and ask. If there's anything that you haven't understood, something that you want me to repeat, you can definitely ask here itself. Okay, I don't see any questions in the chat box. So we'll begin with the discussion. If you still have any questions, we can take it at the end of the class. Okay, so now there are a few definitions which are very, very important from a nephrotic perspective, both theory, practicals, and clinical perspective. So we look at those definitions. Now, these definitions are according to the latest guidelines, which is the ISPN 2021, which is from the Indian Society of Pediatric Nephrology. The latest guidelines have been updated in 2021. So that's what we're going to refer to. So a few definitions that are a must know, not just for theory perspective, but you will use these definitions very often when you're actually investigating and treating a child with nephrotic. So what is nephrotic range proteinuria? So when you have urine protein +3 or +4 on your dipstick analysis, or your spot urine protein by creat ratio is more than 2 on the first morning urine sample, that becomes very important. Or if your proteinuria is more than 40 milligram per meter square per hour over a 24-hour collection of your urine. So that's point number one. So what is the definition of nephrotic range proteinuria? This is very important to know because once you know this definition, you'll be able to classify the patient as having either nephrotic range or non-nephrotic range proteinuria. What is remission? Okay, so once you've say had a patient with nephrotic who's had an episode of first, like for example, the first episode of nephrotic, you need to know when he goes into remission. So you define remission as urine protein ratio on a spot urine albumin in the first morning urine sample less than zero point 0.2 for 3 consecutive early morning samples. So in 3 consecutive early morning samples, when you have a urine protein by creat ratio less than zero point 0.2, or if you have a urine protein that is less than or equal to +1 on your dipstick, you call the patient to be in remission. That means he has responded to the kind of treatment that you've given the patient. Okay. Now, what is relapse? Okay, say the patient has had a first episode, you treated the patient with steroids, has achieved remission, but is coming again with, the second episode, which is going to be the relapse. So relapse is defined as urine protein of more than equal to +3 on your dipstick, or your urine protein by creat ratio of more than 2 for 3 consecutive early morning samples for a person who's had or who's been in remission previously. So, like I said, if you have treated a patient of nephrotic for the first episode with steroids, he's responded, he's gone into remission, and now he comes again with, say, 3 consecutive days of urine protein +4, or if you do a spot urine albumin, then the ratio of urine protein by creat is more than 2 for 3 consecutive days, then you say that the patient is now having his first relapse of nephrotic. Okay, so the first episode that the kid has is known as a first episode, and the first relapse is going to be the second episode of nephrotic that they come with. Now, three again important definitions are frequently relapsing, steroid dependent, and steroid resistant nephrotic. So, frequently relapsing, that means the rate of relapse is frequent, as the name suggests. So, as if you look at the definition, if you have 2 or more relapses in the first 6 months after stopping the initial therapy, or if you have more than equal to 3 relapses in any 6 months, or more than equal to 4 relapses in 1 year. I know these numbers might sound confusing and you must be like, why am I supposed to remember? But we look at why these definitions are important, but at least you need to just know these terms And the more you kind of go through it, it's going to be easier to remember it. But these definitions become very important when you're actually treating a case of nephrotic. Okay, so this is the definition of frequently relapsing. You can go over it later. Steroid dependence is any patient who's had two consecutive relapses when the patient is on either receiving alternate day steroids or within 14 days of discontinuation of steroids. Whereas steroid resistant is somebody who has no signs of remission or lack of complete remission in spite of receiving steroids at 2 mg per kg per day for 6 weeks. So say you've started this patient who's had a first episode of nephrotic with steroids. He's received 2 mg per kg per day daily for 6 weeks, but still there's lack of complete remission. Then you name that patient as steroid resistant. That means he's not responding to steroids, and you need to start the patient with steroid sparing agents. Okay. There's another thing called complicated relapse, where the relapse is associated with life-threatening complications like hypovolemia, acute kidney injury, severe infection, or thrombosis. And just remember, steroid toxicity signs will include hyperglycemia, obesity, short stature, raised intraocular pressure and cataract, myopathy, so usually a proximal myopathy, they'll have weakness of the proximal upper limb and lower limb, osteonecrosis and psychosis. So these are, so if someone asks you what are the complications of steroid or what are signs of steroid toxicity, it's just remember it's hyperglycemia, short stature, raised intraocular pressure, cataract, myopathy, obesity, etc. Okay, so these are a few definitions that I know they're a little difficult and confusing to remember, but they're very important and you should try and remember them as much as you can. At least definitions of nephrotic range proteinuria, remission, relapse, frequently relapsing steroid resistant is something that you should know. And these definitions will also be important, I think, from your need perspective. So it's a win-win that you have to do it for this, might as well do it for that as well. Yeah. So like I said, these definitions are according to the ISPN 2021, which is Indian Society of Pediatric Nephrology. There are other definitions like the KidGo 2021, but what we kind of will stick to is ISPN. So steroid sparing therapy, like I was saying, for somebody who's steroid resistant, he's not going to respond. Then you start with uh, treatment like levamisole, mycophenolate mofetil, that's MMF, cyclophosphamide, CNIs, which is a calcineurin inhibitors, and rituximab. We'll look at these soon. So you know that you have a patient of nephrotic. Okay, so you have summarized in your diagnosis that this is a child with generalized edema or renal etiology, most likely nephrotic. Obviously, the next question that will be asked, or the next step that you need to do, is how are you going to investigate this child? So remember, there are basically two investigations that you do for a child who has typical nephrotic syndrome presentation. Okay, so depending on the age of presentation, whether or not there are associated atypical findings, whether it's a first episode or a relapse, etc. The first investigation that you always do is urine analysis. So what all will you look for in the urine examination? Appearance. So proteinuria, when you have massive amount of albuminuria or protein being lost in the urine, remember the urine will appear frothy. Okay, so that's what the appearance will look like. If the child is having decreased urine output, there will also be concentrated urine, so the urine will appear dark colored and frothy. Second thing that you do is you want to look for the quantification of urine protein, because that's where you'll be able to say whether the patient fits into nephrotic range proteinuria or not. So you do a spot urine protein by creat ratio. If it's more than 2, then it again fits into the definition of nephrotic range proteinuria. Or if you take a dipstick sample and you put your dipstick and you measure the urine protein, if it's more than equal to +3 on an early morning urine sample, then you say it's a first episode of nephrotic. Now the same thing, the same definition of the ratio more than 2 and the urine dipstick of more than equal to +3, for someone who's already had a first episode and you want to label him as a relapse, then you need to have these findings on 3 consecutive early morning samples. Okay, so like I said, if it's a relapse, okay, this finding of nephrotic range proteinuria has to be on 3 consecutive early morning samples to say that this child is having a remission of is having a relapse of nephrotic syndrome. I hope this is clear. The third thing that we look for, okay, So very importantly, uh, when you have to evaluate, or you have to quantify the urine protein, you always prefer the urine spot analysis, either your dipstick or your spot urine albumin, spot urine to protein, sorry, spot urine protein to creatinine ratio. So you always prefer the spot urine sample testing. If the results on this test are inconclusive, only then will you do a 24-hour protein estimation. Otherwise, if you already have your answer on this, you don't really have to do a 24-hour estimation of protein, because it's more tedious to do, and it's difficult for a child to collect all his urine that he or she has passed over a period of 24 hours. So if your results from these two are inconclusive and you're not sure whether this really is a nephrotic or not, only then you collect the urine for 24 hours and send it for analysis. Because on the basis of definition for 24 hours, if you have proteinuria more than 40 mg per meter square per hour over a 24-hour urine collection, then you label the patient as nephrotic. But if you have your answers on the urine dipstick and the spot ratio, you don't really have to do the 24-hour collection. Third thing in the urine that we look for is the WBCs, to look for UTI, whether UTI has triggered this episode of nephrotic or whether there's coexisting UTI along with this episode. And lastly, you look for RBCs to look for hematuria. So when you have more than 5 RBCs per high power field, that is the definition of hematuria. But remember, some amount of hematuria in nephrotics is normal, because along with your loss of albumin, you can also have loss of some amount of RBCs in the urine. So you can have some amount of hematuria. The normal urine examination in a nephrotic will show some amount of hyaline or granular cast, and occasional hematuria is common. But if somebody has gross hematuria or persistent hematuria, then that's something that needs to be considered. Okay. So this is the first thing that you'll do. You'll always do urine analysis, starting with appearance, spot urine testing, and then you send it for WBCs and RBCs to look for UTI and hematuria. If you feel that on the basis of urine WBCs you have uh, the presence of a UTI, then you should always confirm it and send a urine culture before you start your antibiotics, to look at what organism and what antibiotic sensitivity or resistance pattern that particular organism is having. So in all the definitions that I've spoken about, I've always mentioned first urine sample in the morning, first morning urine sample. What is the significance of this first urine sample? Why can I not take like an afternoon sample or an evening sample or a night sample? I mean, what is the significance of taking the first urine sample for defining or categorizing a patient as having proteinuria, or say nephrotic range proteinuria? So the answer for that is there's something called as orthostatic proteinuria. What does that mean? As the name suggests, orthostatic. When the patient sits up or gets up. In kids, there is this phenomenon called orthostatic proteinuria, that when they start moving around or where they're in the upright position, there's some amount of proteinuria which is normal. Now, the exact mechanism for this is not known, but it is a common physiology in kids to have some amount of proteinuria when they're in the upright position. So what happens is, as soon as the kid wakes up in the morning, if you collect the first urine sample, you'll be able to rule out this orthostatic proteinuria, okay? Because the child has just woken up. So whatever proteinuria that you're seeing is definitely not orthostatic, okay? Because the child has not started moving around yet. So this is the significance of testing your first morning urine sample to be able to quantify whether this patient is nephrotic or not, because you want to rule out orthostatic proteinuria. And once that is ruled out and you have the definition fitting into nephrotic range proteinuria, you can be sure that that's what you're dealing with. Okay. So first analysis, like I said, is urine. Second investigation is your blood test. So you look for renal function test with serum electrolytes, serum albumin, because if you go back to the triad of nephrotic, you have hypoalbuminuria, nephrotic range proteinuria, and edema. So the definition wise, if your albumin is less than 3 grams per deciliter, again, that fits into your nephrotic. You look for CBC to look for infection, HB and hematocrit for hemoconcentration, and platelets for thrombocytosis. Now, hemoconcentration and thrombocytosis both predispose to thrombosis, so that's something that you need to be careful about. to see how severe the thrombocytosis and how severe the hemoconcentration is. The hemoconcentration will, or the hematocrit will also give you an idea of the fluid status in the body, whether the child is hypovolemic, euvolemic, whether you need to resuscitate with more fluid, or you can give diuretics for someone who's bloated up. So a simple CBC will give you a lot of insight as to what is the fluid status of the patient. And obviously lipid profile. These patients also have hypercholesterolemia, hypertriglyceridemia, so you might have an abnormal lipid profile as well. Other tests which are very important is a MON2. Always remember that before starting steroids in a nephrotic, you have to rule out tuberculosis by doing a MON2 test. Now, if your MON2 is positive, then you do an X-ray. If it's not, then you don't have to. If your MON2 is positive, okay, but your X-ray is not really suggestive of tuberculosis, or if you send a gene expert, there's no bacteriological or radiological evidence to suggest that there is underlying tuberculosis, but you have a MON2 positive, then you will give 6 months of isoniazid prophylaxis along with steroids, because you want to, like, cover your treatment of tuberculosis, and at the same time you can't really prolong steroids for too long. So under cover of isoniazid for 6 months, you will also treat that nephrotic with steroids. So remember, three investigations that you have to do in a nephrotic is your urine analysis, blood test, and third most important, don't forget MON2, especially before you starting steroids. Now, so when you're asked how will you investigate the patient, you will only mention these three investigations in the beginning, and then you will say that in case if you're suspecting a secondary cause of nephrotic syndrome, only then will you go ahead and send these second line investigations, which is like a C3, C4, or ANA, dsDNA, ASLO. These are all investigations that you send when you suspect vasculitis, and we know that vasculitis is like you have HSP, SLE, etc., are secondary cause or predisposed to secondary cause of nephrotic syndrome. So if you're suspecting these causes, only then will you send these investigations. So if the patient is having gross or persistent hematuria, sustained hypertension, and you're suspecting a secondary cause of nephrotic, only then will you send these vasculitis markers. Similarly, HIV, hepatitis B, hepatitis C, or triple H, they are also causes of secondary nephrotic, but only if you have a history of jaundice or you're suspecting a liver disease, which is, then predisposing to secondary nephrotic, will you send these investigations. So if a patient is having, like, age of presentation, say between 3 to say 10, 12 years of age, which is the usual age of presentation of nephrotic, is having a very usual presentation, no gross hematuria, no hypertension, no other signs suggestive of, secondary or atypical features of nephrotic, then you don't have to send these investigations. Then you only do a urine analysis, a blood test, and a MON2. If you're suspecting secondary causes, if there are atypical features, or if there's like vasculitis, you have petechiae, stria, purpura, or if you are having long-standing jaundice, liver disease, liver cirrhosis, and you're suspecting triple H, only then will you send these investigations. So don't make this mistake of saying these investigations along with your first line. Okay. And lastly, if you're suspecting renal vein thrombosis, somebody who's having gross flank pain, gross hematuria, then you'll do a renal ultrasound to look for renal vein thrombosis, because like we saw, thrombosis is a common acute complication in nephrotic. But you will only send a patient to get an ultrasound done if you're suspecting renal vein thrombosis, which presents with gross hematuria and severe flank pain. Okay, so these are second line investigations, not to be done in all patients. So just remember this point, don't make this mistake. The next interesting thing is, when do you do renal biopsy in nephrotic? So these guidelines have changed. You need not remember all of them. But if a child is having persistent microscopic hematuria or gross hematuria, so basically all the atypical features, there's AKI which is not responding or not attributed to hypovolemia. There are systemic features like you have fever, rash, arthralgia, etc. There is steroid resistance. If the child has been on prolonged calcineurin inhibitors, or is having reduced kidney function, or prior to starting therapy with CNIs. I know this might sound complicated, but these are the indications of renal biopsy in a nephrotic. Earlier, they used to consider age as another criteria for doing a renal biopsy, like if it's less than 1 year or more than 12 years of age. That again was an indication of doing a renal biopsy in nephrotic, but that indication has changed now. Age is no more a criteria. So these are a few definitions or a few indications of doing a renal biopsy in a child with nephrotic syndrome. Having said that, the next question that I'd like to ask is, what is the most common finding that you will see on a kidney biopsy? So we know that the most common type of nephrotic is going to be a minimal change disease. You have other varieties like focal segmental glomerulosclerosis, membranous, membranoproliferative, etc. So say you're performing a renal biopsy for etiology of nephrotic, maybe the child has one of these atypical features. What do you think you're going to find on the kidney biopsy? Is it going to be minimal change? Is it FSGS? Is it membranous, membranoproliferative? What do you think? This is a question for you guys. You can put the answer down in the chat box. Okay, so the answer is that irrespective of it being atypical nephrotic presentation, the answer, you will still see minimal change disease as the most common histopathology on a kidney biopsy in a nephrotic. So that's one point that you need to remember, that that is the most common. Obviously, majority of your minimal change disease patients will respond to steroids, but you might have some who are steroid dependent or steroid resistant, and that is what you will find on their kidney biopsy. So next question is going to be how you're going to treat this child. So always remember, before starting steroids for a patient with nephrotic, you have to treat the infection first, or else the disease will flare up and develop pseudo resistance to antibiotics. So remember, if you have like a UTI or a URI that you think has predisposed to this episode of nephrotic, always start with treating the infection first, and you then introduce your steroids, because steroids are not life saving. It's not like an emergency that you have to start steroid the day you diagnose nephrotic. It's always wise to treat the infection first and then start your steroids. So how do you treat the first episode of a nephrotic syndrome? So you give 6 weeks of prednisolone at 2 mg per kg per day in 1 or 2 divided doses. And then after 6 weeks, you give 1.5 mg per kg per day of steroids for another 6 weeks on alternate days as a single morning dose. Okay, so first 6 weeks of 2 mkd in 1 to 2 divided doses daily. And after that, you give another 6 weeks of 1.5 mkd on alternate days, single morning dose. This is something that is a must to remember. You have to remember this. So it's a 12-week course for the first episode of nephrotic, 6 weeks, 6 weeks, 2 mkd, 1.5 mkd, daily, alternate days. Remember to always give steroids with food because it can cause gastritis. You don't really have to give antacids with steroids, but always like never give it empty stomach. Try to give it with food. And remember, once you start steroids, it takes about 4 to 7 days to start seeing the diuresis. So it's not like you started steroids today, and if the child is having ascites, you'll start seeing him respond tomorrow. It's not going to happen. It takes about 4 to 7 days for steroids to start acting and help in relieving the edema. So that's how you treat the first episode of nephrotic. Now, one interesting question that I always had, even when I was a resident, is how do steroids act in nephrotic? Like, why are steroids the mainstay of therapy in nephrotic syndrome? So, unfortunately, the answer is not exactly known. But what is hypothesized is that nephrotic syndrome is a disorder of immune system. Okay, so you have T cell dysfunction, and it's the T cell dysfunction which causes the food process of podocytes to undergo effacement, which leads to proteinuria. So basically, it's considered that nephrotic is a disorder of the immune system, and we know that steroids have anti-inflammatory and immunosuppressant action. Okay, so it helps in correcting, or it helps in treating the T cell dysfunction. That is one reason, or that's one action, because steroids are anti-inflammatory. And the second thing, which has been found over the years, is that steroids also help in stabilization of the cytoskeleton by alteration of gene expression. So, we saw in the first class in the pathophysiology of nephrotic that there is effacement of podocytes. There is a change in the charge and the space of the pores in the glomerular capillary membrane, which allow the protein to be filtered and come out in the urine. So it has also been proven to a certain extent that steroids help in stabilization of the cytoskeleton so that the excretion of larger molecules like albumin, protein, etc. is not allowed across the glomerular capillary membrane, and you can stop the albuminuria, which is like uh, the crux of nephrotic. So this is what is known yet this is not the complete answer. But I always found it very intriguing as to why do we give steroids in nephrotic. So this is the reason why or how steroids act in a nephrotic syndrome. So we saw the treatment of first episode. Let's look at relapse. So if you have a relapse, you will give prednisolone at 2 mg per kg per day daily until the child achieves remission. So we saw remission was when you have 3 consecutive early morning samples with a urine dipstick of +1 or less than +1, or if you have a urine protein by creat ratio less than 0.2 on 3 consecutive early morning samples, then you label the patient as having a relapse. Okay, so you will give prednisolone at 2 mkd till the patient has achieved a relapse, and then you will follow this with a 4 week of 1.5 mkg on alternate days. Okay, so you give predni at 2 mg per kg daily until remission, and then 1.5 on alternate days for 4 days. You never stop steroids abruptly because it leads to steroid resistance and it leads to your suppression of your HPA axis. So it's always steroids are always tapered. You just never give steroids and stop immediately. You never do that. Okay, so this is how you treat a relapse. Now comes the interesting part as how do you treat a frequently relapsing nephrotic? Now this is important because the treatment of a frequent, so this definition or this treatment protocol that we saw is for somebody who's infrequently relapsing. Say he's had the first episode at the age of 3 years, second at 4 years, the third one at 6 years. So then you label the patient as infrequently relapsing, and this is how you treat an infrequently relapsing nephrotic. But say you have somebody who's frequently relapsing on steroids, then you treat them with a low dose steroid. So basically, what does it mean? That they are requiring steroids for a longer duration, but you can't give 2 mg per kg per day because that's too high of a dose. And steroids do not come without side effects. So what you do is you give a low dose of steroids on alternate days. So you give like 0.5 to 0.7 mg per kg per day for a longer duration, say about 6 to 12 months. So you continue low dose steroids for a long duration of time. If the child, in spite of receiving this low dose for longer duration, is developing signs of, say, steroid toxicity or a complicated relapse, or if your threshold of steroids, the amount of steroids that you're needing to give is becoming more. Okay, so if the patient is required, if you look here, the patient who relapses at a steroid threshold of more than 0.7. Okay, so like for example, if you've started the child on 0.5 mg per kg, but you think, oh, he's still relapsing, you increase the low dose alternate day steroid dose to 0.7 mg per kg per day, and then you give it for longer duration, so you give it for 9 months. But if you feel that the child is relapsing on that as well, which is a higher dose, or if he's developing signs of steroid toxicity, that means you cannot give more steroids. That's where you have the role of steroid sparing agents like levamisole, MMF, cyclophosphamide to begin with. If they don't respond to that, the next line treatment is going to be the cyclosporin and tacrolimus, which are calcineurin inhibitors. If that is not good enough, then the last resort is going to be rituximab. So this is the importance of defining a patient as whether or not he's steroid uh, sensitive, steroid dependent, steroid resistant, frequently relapsing, infrequently relapsing, because the treatment of frequently relapsing and steroid dependent nephrotic is different from somebody who's steroid sensitive or steroid resistant. So just keep in mind that if you have a frequently relapsing nephrotic or a steroid dependent, basically you need to give a longer duration or a longer course of low dose steroids. And if the patient is developing relapse on that as well, or is having signs of steroid toxicity, then you need to stop steroids and move to steroid sparing agents like levamisole, cyclophosphamide. If that is not enough, then the next line of drugs are going to be your calcineurin inhibitors like cyclosporin, tacrolimus. If not, then last is rituximab. Just keep this flowchart in mind. And it's important because you might be asked, how do you treat a frequently relapsing or a steroid dependent nephrotic syndrome? If that is what you have given as your diagnosis, that this is, a patient with frequently relapsing, then you will definitely be asked how the treatment of this is, different from any other typical nephrotic syndrome. So just names of steroid sparing that you need to know. You don't really need to know the dose and the side effect, but this is important because when we start these patients on steroid sparing agents, the dose is different for each one. The duration and how they need to be given is different. And also, again, all of these chemotherapeutic agents, as we call them cyclophosphamide, cyclosporin, etc., they all have a lot of side effects. So monitoring these patients for these respective side effects is also very important. So we need to send certain investigations at, say, every 1 month, every 3 months, etc., depending on what treatment agent you're starting with. So remember names: levamisole, cyclophosphamide, mycophenolate mofetil, cyclosporin, tacrolimus, and rituximab. So this is how you treat a patient with nephrotic. We saw the treatment of first episode, relapse, frequently relapsing and steroid dependent. And if you have a steroid resistant nephrotic, like I said, it means they are not going to respond to steroids. Then your next line of management is going to be starting the steroid sparing agents. Okay. Now, once you know how to treat a patient, there are a few important things with respect to monitoring, counseling, supportive measurement, or supportive therapy in nephrotic, which is very important. So let's just quickly look at that. So how do you teach the parents the urine protein monitoring? See, remember, nephrotic is a disease where the contribution and active participation of the parents and the child is extremely important. I would say it is more important than the role of the doctor, because what we do is we give steroids and then we ask them to follow up. Now, what really happens after discharge is all in the hands of the patient and the parent. How much they have understood what the disease is, how much are they compliant with the therapy that you have told them, what do they know about the disease, how early are they able to pick up relapse and come back to you, whether they really have understood how to take the steroids. Because what happens a lot of times, we tell them that the steroids need to be taken for 6 weeks. When they're discharged, say they have medications for just 2 weeks and they have to come and refill the medication after 2 weeks. And if they haven't understood that the steroids have to be continued and they need to come and refill their medications once it's over, they might just stop treatment by the end of 2 weeks, because by then the edema has resolved, the child is a lot better. So if you don't emphasize that, this treatment is a chronic treatment, it needs to be given for a longer duration of time and you have to take it. If that is not reiterated to the parents, then they might just stop therapy when they feel like. So that is why active participation of the parent and patient becomes very important in a nephrotic. So it's recommended that the patient and the parent be taught how to maintain a record of proteinuria, infection, and the medications received. So you ask them to buy a small diary and you make this little table for them every day. So you put a date. They need to measure the protein, urine protein. So either they can do a dipstick or they can do the conventional method of the analysis. I'll tell you how to do it at home, because urine dipsticks are also expensive. So not all of your patients will be able to, afford one dipstick every day. So I'll tell you how to do a conventional or, a cheaper method of urine protein estimation at home. Then they'll have to mention what dose of prednisolone they're taking. So, like for example, if they're taking 20 mg, 15 mg, 40 mg, 60 mg, whatever it is, that needs to be written, because accordingly you will taper the dose. Like for example, you give 6 weeks of 2 mg per kg and then 6 weeks of 1.5. So it's easier for you also to calculate when the patient comes back for a follow-up, that what date and what dose of steroids has the patient already taken. Any other drugs, if the patient is on, like any antihypertensives, any other drugs, like for example, if the child is having so like I said, hypertension, um, other immunosuppressant, like along with steroids, they're also receiving steroid sparing agents. then that needs to be mentioned. Okay. If the child is having uncontrolled or prolonged um, abnormal lipid profile, then whether or not the patient is on any statins or any other drugs, which is not very commonly given, but any other drug that the patient is on, any antibiotics that you discharge the patient on, okay, for for the infection that triggered this episode of nephrotic, is all going to be mentioned in this box of other drugs that the patient is on, and whether or not there are any problems or any other remarks that the parents want to write. Okay, so this is one table that you need to draw in the in the patient's diary. Explain to the parents what it means and what they need to do, and tell them that when they come for a follow up, they're supposed to get this diary back. Otherwise, what happens? They come for a follow up to you in the clinic, but the diary is lying at home. So again, that is of no use. So that's why early recognition of relapse can help prevent complications. So you need to tell them that if the patient is, having significant proteinuria, which is more than equal to +3, or if the urine output is decreased, if the child is having any kind of infection, fever, UTI, URI, all of these are conditions that will predispose them to a relapse. And that's why they need to identify them and come to you as soon as possible. And active participation becomes extremely important. Okay. So once you've understood how you tell them or how you teach the family how to do urine protein monitoring, few points about supportive care. So always educate the family about the disease, the prognosis, and the future. Okay, any parent who's coming with this child who's bloated up and decreased urine output, eyes have become so small, periorbital puffiness, ascites, etc., they are going to get paranoid. They are going to get worried as to what is happening to my child and what is going to happen in the future. Is he going to keep having these episodes? Is he going to have renal failure? Is he going to have kidney transplant? So there are a whole set of questions that these patients have, the parents have, about the disease prognosis and the future. So that is something which is very important for us as clinicians, to tell them what to expect out of the disease, what the prognosis in the future is. We'll see that. Then daily diary management, or record, is something that you need to teach them. We just saw that. Teach them how to identify relapse and complications. There is certain specific dietary advice that needs to be given. So do not discharge your patient before you've given them this dietary advice. Stress dosing of steroids. So for those patients who receive steroids for a longer duration of time, they tend to have your hypothalamic pituitary axis suppression. So when you have, or when they have a a major event, like they're undergoing some major surgery, they are having some major illness, at that point of time, because your HPA axis is suppressed, you need to give stress dosing of steroids. So a higher dose of steroids for a few days to cover up that HPA axis suppression. So that is something that you need to keep in mind, that if you have a child with nephrotic who's received steroids for a longer duration, when he's having any major surgery or major illness, they do need this stress dosing of steroids. Okay. And lastly, for somebody again who's been on long-term steroids, you always have to assess regularly their anthropometry and look for signs of toxicity like hypoglycemia, obesity, cataract, osteoporosis, short stature, cat, glaucoma, myopathy, etc. Okay, so these are other things which are not directly related to treatment of nephrotic but are equally important, okay, when you're managing a patient with nephrotic syndrome. So like I said, if you don't have a dipstick, then how do you measure your urine protein? So what you tell the patient is, you take urine and you add the same amount of salicylic acid in the urine sample. So it's the ratio is 1:1. Salicylic acid is something that is given to them in their bottles before they get discharged, or even when they come for follow-up in the OPD and they say that the salicylic acid liquid is over, you would prescribe it and they get it free of cost from the pharmacy. So you measure, or you add urine and equal amount of salicylic acid, and then you shake it gently, and then you leave it, and then you read it. Okay, so what you see is, you'll be able, this is a crude method of your urine protein estimation, but if after adding the salicylic acid, the liquid still looks like urine, I mean, there's no change, then it's +1. If it becomes slightly turbid like lemon water, it's +2. If it becomes more turbid or whitish like milk, it's +3. And if it starts curdling or starts settling like curd, then it's +4. So it's same as urine, lemon water, milk, and curd, plus 1, 2, 3, and 4. So this is a crude way of estimation of your urine protein. Obviously, this is not standardized, but for somebody who cannot afford to buy the urine dipstick, this is like an indigenous way of measuring your urine protein. So this is something that we teach the parents and we make them do it in the morning in the ward before the child is discharged. So they know exactly how to interpret it and they can do it again at home. Okay. Now, what dietary advice will you give these patients? So their protein requirement is a little more than a non-nephrotic. So the RDA is about 130 to 140% of what is recommended for a non-nephrotic. Okay, so they need to take about 1.5 to 2 grams of per kg per day of protein daily. For somebody who's having chronic proteinuria, their protein intake is a lot more. So it's like 2 to 2.5 gram per kg per day because you need to replace whatever is being lost in the dietary intake. Salt restriction is important for those who have severe edema. Okay. And obviously, you don't want them to consume more fat and saturated fats. So that intake of junk food and saturated fats needs to be regulated. Now, having said that, a lot of us refer these patients to the dietitian to get a proper dietary plan before they get discharged. But some things, some very easy daily to do things that you need to explain to the mother is that they can add salt while cooking food. Okay, so what a lot of mothers do once you say that salt restriction, that means they just stop adding salt in the food as well. And then the food becomes so bland. Obviously, the child is not going to have that kind of food. So you need to tell them that whatever amount of salt is required for normal cooking, that is okay. You do not need to add extra salt on the food or avoid consuming foods that have excess salts, like your chips, fried food, pickle, papad, cheese, canned preserved foods, bread, etc. So you don't give these foods that have extra salt in it, especially when there's severe edema. Now, again, these are kids, they are going to ask for these things. So you need to be very careful in telling the parents that you need to balance giving what they want and at the same time not making them irritable. Otherwise, they're going to have a hell of a time. So avoid giving foods that have extra salt and avoid adding salt, on top of the food. But you can add food while cooking. You can add salt while cooking your normal food. So that is allowed. So that is something that you need to emphasize. Otherwise, moms start giving bland food and the child will just stop eating. So this is the dietary advice that you will give to parents in a case of nephrotic. Last but not the least, what is the prognosis in future? So they'll keep asking you that, is this going to happen again? How long are the steroids going to be required? Is my child going to be fine? Is he going to have kidney failure when he grows up? You need to tell them that, after the first episode of nephrotic, about 23% of them achieve complete remission. Okay, so they might just never have an other episode of nephrotic. Whereas about 43% of them may have relapses, but they are infrequent. Okay, so they don't fit under the definition of a frequently relapsing, so they're infrequent relapses. About 30% of them might have frequent relapses. So you will have to give probably steroids, low dose for a longer duration of time. And it's only less than 1% of patients who develop end stage renal disease. Okay, so that is very uncommon. It is a complication that you don't really need to worry about in the initial few years of nephrotic. You need to tell the parents that as the child grows, he'll outgrow the disease. Okay, so these episodes will stop once he's about say 10 to 12 years of age, depending on what age he had the first episode. But what you need to emphasize on is the fact that if you started the patient on steroids, they have to be compliant with the drug, with the dose, with the duration. They need to be compliant with follow-ups. They need to know when to come and show you. They should actively participate in maintaining the daily diary, being able to identify relapses and complications, and they should know when they should come to you. So these are points that you need to emphasize on when you're actually counseling parents whose child is a nephrotic. So you don't have to scare them, but at the same time, you need to tell them what is important and what is required from them as participation along with your treatment that you're going to give the child. Okay. So this is what you kind of tell them about the prognosis in future, and this concludes our discussion on nephrotic. So thank you guys for attending. I hope this session was helpful, and I'll see you guys next Saturday for a discussion on another topic. Till then, study well and enjoy. Thank you.